for some reason.
I don't know why it's doing that. But I'm going to go ahead and read a housekeeping announcement. This meeting is going to be recorded, so anything viewed on the webcam or typed in the chat box or said verbally will be recorded and posted on our website. We'll monitor the chat box for questions. If you could please identify say your name before you state your remarks. That'll be helpful for everybody. If you're on with your phone only, sometimes you'll need to hit *6 to unmute yourself. And thank you for your participation and patience. All right, Dr. Castro-Marin.
Thanks, Shelley. It's 12:04 p.m., so we'll go ahead and call to order. Shelley, could you start us off with a roll call, please?
All right. Amber Rice. Here. Erin O'Connor. Where'd she go?
I'm here. I'm sorry. I was on mute. Apologies.
All right. Brian Smith.
Here.
Chester Keith.
Here.
Franco Castro-Marin, we've got you. Garth Eamer.
Present.
Heather Miller.
Present.
Jason Johnson. Jason Payne.
Present.
Josh Gaither.
Present.
Matt Shaw. Neil Gayo. Paul Dabrowski. Shari Brand.
Here.
We have quorum. I counted 10. We needed 8.
Okay, thank you. We'll go ahead and start off with the chairman's report, please. Hello?
Dr. Castro-Marin, did you get my email last night? It's just real brief. We just have a couple items. The attendance report and the meeting schedule.
Got it. So thank you. Yeah, I have that. So just a friendly reminder that if you miss 2 consecutive meetings, the Bureau will contact to ask you if you're still interested in serving on the committee. No new members or vacancies are available. There's no vacancies at this time and no new members to announce at this time. And the 2022 meeting schedule should be posted for everybody to review. Shelley, are you needing any more comments on that from me at this time?
We kind of firmed it up with our usual third Thursdays. And then the conference room is subject to change.
Yeah. Okay. Here's the right page here. All right, let's go ahead and start with the Bureau report, please.
All right. Good afternoon, Dr. Castro-Marin and committee members. This is Rachel Garcia. I'll share some department updates as well as some updates from the Bureau of EMS and Trauma Systems. The state budget has been approved. The Bureau's budget this year has been approved for a slight increase, but we expect actual funding to remain level compared to recent years. The Bureau also has several vacancies that are listed on our state jobs website accepting applications, including a position for education and training. In the last month, we've also welcomed new hire Travis Connors as a project coordinator within the Bureau. He joins us today and will provide a brief introduction after updates. Arizona's reached a new milestone in the pandemic response and recovery. Governor Ducey has rescinded several COVID-19 related executive orders. The executive order for the emergency declaration, as well as enhanced surveillance advisories and surge line implementation remain intact. The department continues to monitor cases and also recommends vaccination as the best form of protection against the variants that have been detected in Arizona. The Bureau is working closely with ADHS licensing as well on an update of a current policy statement on the use of EMCTs in hospital settings. With the licensing of hospital at home programs on the heels of the pandemic, we expect the use of paramedics and EMTs in these programs to follow the same guidance as traditional hospital settings, and that would include requirements for scope of practice and medical direction. The department continues the regular rulemaking process for ground and air ambulance rules. New drafts for both ground and air ambulance are posted on the website at azhealth.gov for comments through August. The informal draft process for both air and ground rules are expected to continue through 2021, with plenty of opportunities for more comments before moving forward to the formal process. EMS scope of practice updated, recommended by the Medical Direction Commission, is also still pending. That's been sent over to the governor's office. We're still waiting to hear back. We would expect adoption of scope of practice, the new recommendations for scope of practice this year, but it's important to note that we still have several exception requests pending at this time. That is all I have for now, pending any questions. Thank you.
Thank you. Any questions for Chief Garcia? Okay, thank you so much. New Bureau staff, is there an introduction there?
Yeah, hi, can everyone hear me?
Yes.
Yes, Travis.
Hi, so my name is Travis Connors. I come over from the medical marijuana program. I was the program manager over there before coming to the Bureau of EMS and Trauma. And as Rachel said, I am a project coordinator with the Bureau. My background is in public health. I have an MPH. So one thing I want to touch upon today was the new e-certification cards. So the Bureau has implemented a fully online EMCT certification process, which includes the issuance of electronic certification cards. That was effective July 1st of 2021. The Bureau is no longer printing and mailing cards. We do have an updated FAQ document that is hyperlinked to our announcement on our webpage on the home screen, as well as the EMT certification tab as well. Page 6 is where you'll start seeing those new updates to the FAQs in regards to the digital certification card. And that includes how to view and access the card, print the card from a computer, save it as a screenshot or as a PDF document to your mobile device. That is the only update I have for today. If anyone has any questions, you can feel free to email me at travis.connors, that's CONNORS, @azdhs.gov. Thank you.
Thanks, Travis, and welcome. Look forward to meeting you in person hopefully soon. Dr. Bradley, any updates on the naloxone Leave Behind program?
Sure, thank you very much. So I just wanted to bring this topic up again. I know I've been bringing this up the last few meetings, as I'm sure anyone who's been watching data that's coming out from 2020, now that we're about halfway through 2021, really across the nation as well as here and within Arizona, we've been able to look at opioid overdoses and deaths. And unfortunately, alongside COVID, we have seen an increase in all of those numbers statewide. The department, so all of ADHS, is really looking at refocus on a lot of the opioid-related activities. And so we're trying to bring attention back to the naloxone Leave Behind program. One of the things we're trying to do is to really streamline and expedite this. So any agency that would like to participate this with approval of their administrative medical direction, they could really go to our website and download all the documents they would need to go live with this program. So the Education Committee just last hour approved an updated training PowerPoint specific to naloxone Leave Behind. I think this will be a really easy to use training PowerPoint. There's also a draft sample brochure that can be given to patients who you're administering or distributing naloxone to, and that can be customized to your geographic area. Lastly, and probably most importantly for EMS agencies, the Office of Injury Prevention, which falls under ADHS, has funding to supply EMS agencies with free naloxone. This is the commercially prepared 4 milligram intranasal dose of naloxone. The box comes in a 2-pack, and so there is funding available to provide free naloxone to EMS agencies who are interested in doing this program. So we really wanted to spread the word on the program. Like I said, you'll hear us talk about this at all the standing and statutory committee meetings, and we're also going to start spreading the word as well at the regional councils. But our hope is to make this as easy to implement for an agency. Good point that Dr. Gaither brought up at the last meeting. The training PowerPoint can really be customized by an agency's medical director to fit their jurisdiction. So if a medical director is not so comfortable with all of it, they could adjust it as they saw fit. But really, it's something that an agency could go live with and really implement very easily. I did just actually deliver the education training last week in 2 sessions as a practice, and really found that it was useful for EMS. It kind of reframes their mindset looking at substance use disorder and opioid overdose, and kind of helping to change their framework and mindset with that. I will take any questions anyone has on that.
Thank you, Dr. Bradley. Any questions for Dr. Bradley before we move on? All right, thank you. Share update, Julia Vincent.
Hello, everyone. Just a couple of updates for share. First of all, the Bureau is in the process of recollecting documents from cardiac receiving and referral centers. The messages have been sent out to all centers as of last week. If you have any questions about that process, you can send them to myself or Gail, Dr. Bradley, and we would be happy to answer them for you. Dr. Bradley, did you want to add anything to that about that process?
Sure, thank you. So as a reminder to anyone that may be newer, just to kind of bring back people's recollection of the Cardiac Receiving and Referral Center program, this program has been in place in Arizona for well over a decade. And hospitals that initially applied for this recognition had to submit all of these policies and protocols as part of their initial recognition, which was granted by Dr. Bobrow. As we've had a lot of transition at the Bureau, along with U of A, we've really tried to kind of go through all these programs and ensure that we're still doing our due diligence. One of the things that we noted was at no point since hospitals initially became recognized that had we ever gone back to ensure that these protocols and policies were still in place. Just like any other recognition or certification program, whether it be ACS, chest pain accreditation, stroke accreditation, all those entities require periodic review. And so moving forward, we do plan on having a cycle of every 3 years that we would ask hospitals to resubmit their policies and protocols just to ensure that you still have this in place. What we found as Julia has sent out these emails is that there's obviously been turnover in over a decade. And so there's lots of questions as to why we're requesting this. But really, it's more of a housekeeping issue, and to ensure that when we ask EMS agencies to bypass their closest hospital and bring a patient to you for your cardiac arrest care, that you do still have the right policies and protocols in place to provide optimum care for those patients. Any questions about that? If you have any concerns or questions, please email Julia or myself, but we just wanted to make sure everyone understood why we were requesting that again.
If there are no questions, I'll just add that Bruce Barnhart and the team at AEMRC are currently in the process of reaching out to hospitals that have any missing data records so that they can complete the care report. So if you happen to be missing data, we would appreciate you sending that over to them. And then I'll just move on to EMS for children. Currently, we're in the process of the National Pediatric Readiness Project Assessment. 26 hospitals in Arizona have participated thus far, and we are hoping for additional participation. So I would encourage your participation if you work in a hospital setting that hasn't already participated. We are in the process of hiring for an EMS for children coordinator. We have somebody identified that hopes to start in September, so we're looking forward to that. And then I'll just add last that we have applied for some additional funding for EMS for children, and we will keep you updated on whether or not we receive that. That's all.
Thank you, Julia. Any questions for Julia before we move on? Then we'll get a data dashboard update, please, from Vatsal.
Good afternoon, everyone.
Hi, Vatsal.
Hello. So data visualization page, we are putting now mainly doing the data dashboard since last couple of years now. And as you can see, that we have right now currently 5 dashboards using the trauma registry and EMS registry. The trauma injuries by year is that gives an overall picture of trauma. It's similar to our annual report. And then using the same trauma registries, we have 2 more dashboards, which are MVT and falls, which are the 2 main mechanisms of injuries in the state of Arizona. So that dives deep into these 2 injuries. And then we have EMS incidents by year, which is kind of using the ACPS registry and gives an overall picture of EMS call volume and primary impressions, and some of the important ones, and what is the survival and things like that. And then we also have a ASTR using the trauma registry, a race and ethnicity dashboard, where you can compare each race and ethnicity with others. So all the dashboards, we are trying to keep them updated, as soon as we receive the data, and then, we upload the new data, new year, and then try to keep those dashboards updated. Currently, we have 2019 data with the trauma, and I just received the 2020 data, so we will be updating that pretty soon. And so we also keep on adding the dashboard. So if any ideas you guys have, or please let us know if you would like to see any other dashboard or have any PI related dashboards. We are open to suggestions and ideas. Thank you.
Thanks, Vatsal. Any questions for Vatsal's team or Vatsal? And then the next item on the Bureau report is the digital certification, which starts July 1st. I believe, was that the issue that was covered by Mr. Connors, or is there more comment needed there?
No additional comment.
Okay. Thank you, everyone, for the updates from the Bureau. The next discussion and action item will be item listed A, which is discuss, amend, and approve PMD draft minutes from March 18th, 2021. Can I get a motion to move with this?
So moved, Brian.
Sorry, I'll motion.
Brian, thank you. Can I get a second?
This is Aaron, second.
Thank you. Any discussion? I'm not hearing any discussion items. Sorry, go ahead, please.
Oh, I just said this is Amber, motion to approve.
Thank you, Amber. Can I get a second?
Second, Jason Payne.
Thank you. All those in favor? Yeah. Are there any oppositions? Thank you. The motion passes. We'll approve the minutes. Item B, discuss, amend, and approve creating or updating drug profiles for Table 2 agents eligible for administration of during a hazardous materials incident. Can I get a motion to discuss?
This is Amber, motion to discuss.
Thank you, Amber. Can I get a second?
Second, Jason Payne.
Thank you. So if everybody can see on the board, I'm sorry, I can't see the screen because I'm on phone only. Is there any specific discussion for this? If everybody could see that on the screen?
Yeah, I'm displaying Table 2 agents eligible for administration during a hazardous material incident.
Just a little background on this. As we updated the drug profiles about 1.5 years ago, this was one of the projects we were going to tackle as well, and then we just all got very busy with COVID. But this has been requested from some stakeholders that we look at adding in the missing drug profiles. So we would just need to create a work group on this. I do have someone that's already put together some drafts in our current format as a starting point. So I think we at least have a good starting point for this. And we are fortunate to have Dr. O'Connor as our resident toxicologist who can help facilitate this as well.
And so is this a request for volunteers then for the work group? Is that right?
Yeah, this is Erin. I'm happy to help review any of the documents. I mean, I reviewed this document, but then I'm assuming they're going to be actual drug-related handouts or a file for each drug.
Correct. The current format that we have is a less than one-page document, kind of a summary, indication, contraindication, and then it links them to the specific treatment guideline and the state treatment guidelines that they can utilize them with.
Okay.
Dr. Bradley, how do you want to coordinate any potential volunteers? You want them to reach out to you or Dr. O'Connor directly?
If they can let Shelley know, she will be the one that will help herd all of us into a meeting. So if she's shuffling over there next to us. So yeah, please let myself or Shelley know, anyone who's interested in participating, and we will work on getting those going.
All right. Thank you very much. So basically the action request is to submit any volunteers to work with Dr. O'Connor as the lead to review and update this table with recommendations coming back to this body once that work is completed?
No, specifically this is just creating a work group to work on that. So not adjusting the table at all.
Okay, got it. So is there any specific action item that needs to be voted on besides getting volunteers to work on this today?
This is a motion, right? For this is Amber. I can make a motion to form a work group to look into creating the specific drug profiles needed.
Thank you, Amber. Can I get a second?
Shari, I'll second it.
All those in favor, or are there any opposed to forming the work group? Any opposed? All right, hearing no one in opposition, the motion passes. And we'll get that, any volunteers, please reach out to Shelley to assist with Dr. O'Connor. Thank you, Dr. O'Connor, for taking the lead on that. Item C, discuss, amend, and approve adding TXA, tranexamic acid, to Table 1, the EMCT drug box. Shelley, did we end up getting a lead point person to lead the discussion on this?
Yes, we do. He's on the phone call.
Hi, everyone. My name is Eve Godsdanker. I'm a physician up at Northern Arizona here at Flagstaff and the medical direction for Northern Arizona EMS. So please feel free to interrupt me. Let me know exactly how you prefer to kind of guide us along. We've been talking with Matt Shaw as well about TXA. I know this was kind of brought back to the attention of this group several years ago with HEPA starch together. This time we're just discussing this on its own. This has already been kind of, in 2015, a joint statement from ACEP, ACS, and NAMESP, kind of already stating their position regarding this as well. I'll quickly touch about potential benefit, harm, and EMS's role. Potential harm is always kind of at everyone's forefront when you introduce any kind of new medication. Now we have CRASH, STAMP, MATTERS trials. And all of them have not really shown significant harm by any means. There was a little bit in MATTERS trial, but they did also have a higher ISS group for those who received TXA. So from what we've seen so far, no significant really increase in DVT or PE. Once again, TXA acts as an antifibrinolytic, not as a prothrombotic. So again, it's going to help maintain clots that are present. It's not going to generate, per se, new clots, is some of the thought behind it. Benefits, of course, we've seen this quite varied. NMT tends to be closer to about 30 to 50 in the sense of how many people to treat till we save a life, which is actually, as we know, quite a small number for such an inexpensive medication. And again, for EMS's role over and over in all these studies, they've seen that time to injury and then giving of the medication is of the utmost importance. So who to better provide this medication than the paramedics, the EMS in the field? Again, there's always a question that we want to make sure we minimize time on scene. This is a medication that can be provided along with the fluids, so it would not necessarily result in any increase in time, because we're already asking our paramedics to initiate an IV in the field, so this can be done while en route. So in a kind of brief summary, again, this is a medication that's relatively inexpensive, has significant potential benefit, minimal harm, and it's not really going to increase any kind of scene time. So I would like to bring to the attention if anyone has any questions regarding it as well.
Thank you for the presentation. Can I get a motion to discuss?
Hi, this is Brian. I'll make a motion to add TXA to the paramedics drug box list in table 1. And then I have a clarifying point on this document.
Please go ahead.
So it's noted that TXA was paired with hydroxyethyl starch and LR when it went to MDC, but the November 15th, November 19th, 2015 meeting, both those items, TXA and Hextend, were on the agenda for PMD, and Hextend did not pass, but TXA did pass PMD. However, at the January Medical Direction Commission meeting, where TXA did proceed on its own merit, it was voted down. So I just wanted to clarify that.
I'm happy to
Thank
make
you.
a second to approve TXA.
Thanks. That was Dr. Gaither, I believe. Any further discussion on this point? Do we have dosing parameters identified?
Hey, this is Erin. I guess I'm sorry if I'm new to this and I don't know the whole history. I guess a couple questions. You know, the literature was not 100% conclusive in fully supporting pre-hospital administration. I know it's a bit of a controversy in the medical literature. I guess I wonder, what is the experience with other EMS providers around the country and possibly even internationally, like France or England, who often have physicians on their EMS transports and so forth.
So, Erin, sorry, I'm not familiar with your background. I'll weigh in off the top of my head. The use of TXA in the pre-hospital setting certainly has been a little controversial, but only because we don't have a lot of dedicated pre-hospital data surrounding its use. You are right, it has been used in Europe. They have a different system than we do. The trials out of Europe have been almost universally positive. TXA is in use by several other EMS systems across the U.S. I think the positive to TXA is simply its low side effect profile. Aside from the theoretical possibility of prolonging field time, there's not a lot of downside. So I think in general, the experience across the country in the pre-hospital setting has been, implementation has been fairly easy without significant downsides.
Okay, yeah, I guess for me, it's always been a drug that's had, because of the different indications that it's used for, I feel like in reviewing the documents that were provided today, I didn't have a clear understanding of the criteria for use. I mean, I think we'd have to have well-defined criteria to be met. And then, because obviously there's other indications, right, as far as, postpartum hemorrhage versus traumatic brain injury versus traumatic hemorrhage. There's a whole slew of specific indications. And so I wasn't sure if we were just talking traumatic hemorrhage, and then is that penetrating trauma, is that blunt trauma, is that all comers? What criteria have to be met in order for EMS to administer this drug in the field? And then just looking for a little more clarification around how many patients we think we would actually have a prolonged, like in our state, how often do we have a prolonged transport time in which patients would be expected to have over an hour? You know, because the target window is an hour to 3 hours, you know, to administer this agent. How often does it happen that the patients don't get to an emergency department in that time frame?
This is Sandy. I just have a question. Can you get data from the flight companies? Because I believe they've been using TXA for quite a while.
Yeah, I think, Sandy, you have a good point. I think one of the points to bring up is that our flight companies already use this. Our flight nurses already give TXA. And I think we could spend a lot of time discussing numbers and a lot of months talking about numbers. From my seat, I don't see the point, quite to be blunt. I think most EMS agencies across the country are moving towards using TXA. Yeah, I fully support it. I think to get back to the question originally, I think the role of a administrative guideline in my case, or any other treatment guideline, is to clearly delineate who gets it, how much is given, all that stuff. The drug box or the drug table is simply allowing that to be given.
And thank you. I was going to just clarify. So different states have different ways of kind of regulating how EMS does things. In Arizona, once a drug is added to the drug table, so once it goes on table 1, 2, or 3, it is up to that agency's individual medical director to then determine indications, contraindications. So we put together, in general, kind of the drug profiles with some general, what we think are the indications and contraindications and guidelines to utilize it. But each individual agency's medical director would have to determine for their agency what that looked like. So it is a little unique compared to other states. Once, you know, I've used the statement before I was at the Bureau as a stakeholder. Once we approve something, it's in the drug box. That agency's medical director can use it however they see fit. So I think that is always something to keep in mind as we do approve medications, is that there's different engagement levels of medical directors throughout the state of Arizona. And so once the drug is approved, it's really up to that agency to then determine how and when it would be utilized.
This is Dave. Question: is there any value, for Dr. Connor, regarding CRASH 1, 2, and 3 studies on TXA in the pre-hospital setting for historical purposes?
I'm sorry, was that directed to me, or what was the?
Yeah, you were asking about the background. I don't know if there's any value for historical purposes about the CRASH 1, 2, and 3 studies for pre-hospital use of TXA.
Yeah, I mean, I guess for me, there were supposed to be, was it PATCH and SMASH, I think, are the 2 pre-hospital studies that were being performed. I don't know what the outcomes of those are. I haven't looked at those specifically, or if those outcomes are available. But obviously, this agent, there is some even controversy on how to use it in hospital and whether it really confers mortality benefit, in a prolonged period. So, but as far as what I was trying to reconcile was in the pre-hospital setting, the data seems mixed and somewhat limited. And so then there were these 2 studies that were designed and being performed. But they weren't presented in these documents, so I don't know what the outcomes of PATCH and SMASH trials were as far as supporting or not supporting use of it pre-hospital.
So I'll help you out there. The CRASH trials were done in Europe. They were the pre-hospital use of tranexamic acid. They were positive. They showed improved outcomes in patients with hemorrhagic shock. I believe off the top of my head, they defined hemorrhagic shock as a systolic blood pressure less than 110, although don't hold me to that.
Well, that's the SMASH trials, which I am familiar with those, and those are international, which obviously these are often in a resource-poor healthcare system. But specifically, I think there were 2 pre-hospital like I said, I think they're abbreviated patch, and I can pull them up, but I'm familiar with the SMASH, which had which was a randomized controlled trial, which was double blind.
Eddie, Dr. Connor, you brought up the idea of, conferring benefit to patients when, relatively speaking, transport times are not often, at least in trauma, exceeding 1 to 3 hours. Any further comment on that point, and especially when you put into context the resources that would be needed to train on another medication for EMS agencies when that benefit may not be there for agencies that don't have prolonged transport times.
And if I could add one point regarding the transport time, I know the majority of the population of Arizona does reside between, we can say, Phoenix and Tucson. Working up in northern Arizona, we do tend to see a little bit of longer transport times. So I do, working up here, also down in Verde Valley, to have these longer transport times. So that's kind of one field where I could see that being more of benefit. And regarding the 1 to 3 hour, Dr. Connor, I think you're also kind of referring to the STAMP trial. And again, I fully will state this is subgroup analysis, but they do kind of look further into treatment within less than 1 hour. So that would be kind of an additional window where I see this medication having additional benefit for our patients.
Yeah, sorry, I think I called it SMASH. It's STAMP. But yes.
And no, and I hear what you're saying, right? In the grand scheme, STAMP, they said they unfortunately, at 93% of enrolling patients, couldn't fully get all of it done at that point. And then when you subgroup analyze it, it does bring it to further scrutiny. But I thought they brought forth interesting points, A, to the point of less than 1 hour, B, to the point of the really sick patients, systolic less than 70. Granted, that group was so small. But again, the other thing that was helpful in my mind is just they didn't see any increased risk of harm, by that again being DVT or PE or multi-organ damage.
This is Jason Payne. Any tool that we can give our tribal EMS or our rural EMS providers to put in their toolbox to help have a positive outcome with traumatic patients. Transport line times can be extremely long up in the north and the extreme south. Different areas in the rural areas, especially up north. You have to take into account weather. A major accident, you have somebody that falls under the qualifies for TXA administration, and it may be an hour or 2 hours before you can even get to a hospital that's maybe 30 miles away because you're stuck in a snowstorm. I don't know how often this would be used in central Phoenix or some of the suburbs with as many trauma centers as we have, and the ability for the rapid infusers with blood products. But I strongly support this, and I think this would be a great tool as long as it's an optional tool in both treatment and with carrying the medication in the drug box.
Hi, it's Brian.
Go ahead, Brian.
I realize I need to amend my motion to have that optional. I don't think I said the word optional, so.
Thank you. Thanks for that clarification. My only counter is that, it seems like the sort of the classic example of where this drug might be playing a role, is in the rural communities with weather challenges and prolonged transport times. From a pragmatic standpoint, my only counter to that would be whether or not this one intervention, would truly be life-saving in patients who are, exhibiting advanced stages of shock, who are, basically the examples that you bring up are transport times exceeding an hour, et cetera. The question is, would a dose of TXA be the one life-saving intervention that occurred to save these lives? for as uncommon as those specific scenarios may be. But I understand the question in front of the board today as to whether or not to include this as in the drug box, and then it's up to each individual agency to decide how this tool would or would not be beneficial to their own patient population. And so that's really the question at hand today. Any further discussion points? So then the motion is whether or not to approve adding TXA to the drug profiles, table 1, EMCT drug box. We'll go ahead and put it to a vote in the absence of any other discussion. All those in favor say aye.
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 And any opposed, nay, please. All right, hearing no opposition, the motion passes to add tranexamic acid to table 1, EMCT drug box.
Franco, sorry, just for, can we just make sure there's no abstentions, please?
Oh, thank you. Are there any abstentions on the vote?
This is Aaron. I abstain just because I don't feel like I'm well versed enough to fully understand implications. So, but no opposition.
And that is to
any other? Sorry, last commenter, please repeat.
That's Brian. That is to paramedic.
Yes, to the paramedic scope. Yeah, as an optional agent. All right, so the motion passes with 1 abstention. The next item is to discuss, amend, approve drug profile, an actual drug profile for TXA, which is attachment 5D in your electronic handout. Do we have a lead to discuss these details?
That's Brian. I'll make a motion to approve the drug profile.
Okay. Sorry, I'm having.
Can I get a second? Can I get a second?
This is Shari. I'll second it.
Thank you, Shari. Any discussion?
This is Jason Payne again. I personally think it needs to be cleaned up a little bit with just kind of explaining a little bit more as to what exactly this medication's being used for or who fits in the criteria. As it just stands, the way it's written, it's kind of, I think, reaching.
And this is Eve Godsdanker. Jason Payne, are you kind of stating kind of maybe make more specific inclusion criteria for the indication?
Yeah, not to the point where we have a 3-page drug profile, or you know, even when it gets put into the treatment triage protocols, that it's, you know, extremely convoluted. But yes, I personally think that there should be kind of at least a few this is a horrible word, but more, you know, like examples of, because as I'm trying to pull it up now, I see it on the screen, but there's a point. It just basically says, to me, it just reads as, you know, trauma patients. You know, I don't want it to be misread as, you know, any trauma patient gets TXA with, or, you know, hey, this guy might have an internal bleed. I have no idea. Let's just give him TXA. You know, I think there should be some, at least some poison pills that we have to swallow before we administer this medication.
This is Aaron. I support that. I mean, I think the hemodynamic unstable patients with a systolic less than 90 and a heart rate greater than 110 is certainly going to encompass a lot of trauma patients.
Hi, it's Brian.
Go ahead, Brian.
So I think in more than one of those studies, I think I read, and I think it was in CRASH, the vital sign criteria was less than 90 and a heart rate greater than 120. which I think would, I think you could end up with a lot of issues with going with either one of those without it really being both in there and tied together.
I would be reluctant to just have them tied together, given unfortunately a lot of our elderly population with beta blockers and so forth having possible misrepresentation of those five signs. And for STIB trial, they very much kept it as two separate things, as an or situation.
If I could add maybe a comment, maybe correct me if I'm wrong, my historical recollection was that our drug profiles were meant for educational and informational purposes, that we generally don't include indications, contraindications, dosing, that type of thing in here, although some doses have been included in the past. And that whether we reserve those indications, such as vital sign parameters for the P3Gs or other similar guidelines, protocols, orders. So maybe this is one that we could talk through as a proposed modification to the P3G rather than the drug table.
So I think the drug profiles have kind of general indications and absolute contraindications of how we approved them as we updated them the last time around. We took out a lot of the specific dosing that were in the old version. The previous drug profiles were, I think, 3 pages per medication. And this group did a lot of work to simplify those down to a single page. And so really, when I look at kind of atropine as an example, I just pulling that up, we've got pharmacology and actions, indication, absolute contraindication, precautions and side effects. And then we have onset, peak, and duration, and then the guidelines it links to. But we don't get into specific dosing in that regard.
This is Amber. I have one other minor suggestion related to the indications. I don't have a problem with being somewhat vague, but I think they must administer within 3 hours of injury. Seems like maybe it would be more appropriately placed in the either precautions and side effects or maybe even in the top box. Doesn't really seem like an indication per se.
Maybe contraindication, absolute contraindication greater than 3 hours from injury.
Yeah, I think you could put it almost anywhere else in there somehow, but just not really an indication.
I agree with Amber's point. This is Franco. And then if we keep it, that bullet in absolute contraindication, if we could say administration greater than 3 hours from time of injury.
This is Garth Gamer. Can I bring up another point regarding the indications? Does the indication that it's only associated with use in trauma, does that hamstring us potentially down the line? Because I know that some systems are using it with postpartum hemorrhage, I think even epistaxis, and perhaps even with nasal pledgets soaked with TXA, as well as intravenous administration. So could that be modified to just significant hemorrhage and must administer within 3 hours of injury or onset of hemorrhage?
Do I hear any opposition to Dr. Gamer's suggestion that the indications be broadened to include significant hemorrhage of non-traumatic etiology?
People are going to do that anyway because this is just a guidance document. So it would be safe to do that probably because people will do that anyway if they desire to.
Dr. Castro-Moran, this is Dr. Stites.
Yeah, go ahead.
Hey, I just was looking through. I don't have the document that you all are looking at, but I'm listening to you discuss it, and I'm feeling a lot of kind of protocolization of the drug profile. So I just pulled up like up-to-date TXA and looked at their contraindications, and it's very specific disease stuff. There's no time parameters, as it's not really a contraindication. That's more of a protocol or a guideline. So just kind of FYI that I think we may be going down a rabbit hole here.
And so your comment being that for the drug profile, we should avoid language that starts to slip into the realm of protocol language, or language that should be contained in actual treatment guideline, as opposed to just drug profile general information.
Correct. I think that's the route we've tried to go in the past, is tried to keep the guidelines separate than the drug profile, which is really information about the drug.
Okay, point taken. And so as far as consensus regarding indications, the question is, do we broaden the language to include significant hemorrhage of non-traumatic origin? Is there anybody opposed to doing so based on Brian's last point? If no one's opposed, then the suggestion being that we go ahead and broaden the indications. The other suggestion made was to remove the bullet point regarding administration within 3 hours from the indications section. And then the third suggestion was whether or not we remove the 3-hour time limit from the contraindications. I would be in favor of keeping that myself. Any other discussion?
No, I concur with that, Franco. This Garth Gamer.
Yeah. And again, I apologize. I can't see the visual aids on the meeting, and so we have those edits in place. So is there any other further discussion for any additional edits to the drug profile in its current form?
This is Amber. The only other comment I would make is that we have this area of absolute contraindications and precautions and side effects. It would seem that maybe the last two bullets on there are more of precautions and side effects and less of absolute contraindications. I would just make sure that we keep the absolute contraindications as clean as possible and specific as possible, and these say not recommended, or they're more suggestions than necessarily what I would traditionally consider an absolute contraindication to using a medication.
And so, Amber, do you feel like there's anything else on the absolute contraindication list that needs to be removed or added then?
Well, the not recommended in patients less than 16, I don't know that that's an absolute contraindication.
Okay.
More about precaution and side effects, potentially.
Okay, so suggest moving that bullet point down to the next section.
Yeah, and then your absolute contraindication of giving greater than 3 hours from time of injury, again, is still not an absolute contraindication of the drug. It's just not necessarily effective.
I see.
So it's, again, not an absolute contraindication to using the drug, but more of like in the pharmacology section, or as a precaution that it's less effective in certain populations or groups.
All right, so then the recommendation is to move bullet point 3, not recommended in patients less than 16, to the precaution side effect, and then moving the greater than 3 hours, administration greater than 3 hours for time of injury, perhaps moving that down to the precaution section as well. Any other discussion or comments?
This is Dr. Seitz again. I agree with that. I think maybe even a verbiage change might be indicated to reflect maybe like decreased efficacy after 3 hours, or some sort of change. And then TXA is absolutely used in younger patients. So I mean, if this is a drug profile that we're using, it's used in people under the age of 16. I don't know if it's frequently, but it's definitely used. So maybe we limit that to the trauma setting, or what the studies have shown in that. But as far as the drug itself goes, I would hate to put misleading information on the drug profile. And then I just wanted to clarify something, I guess, about the drug profiles. Are these considered guidance documents? Or do they have any regulatory capacity?
So can you clarify the last part of that question, Dan?
Yeah, so the drug profile itself, I mean, so we're boxing in some of the uses of this in the drug profile by including indications and contraindications. But I know we've discussed several times in the past that if it's on table 1, it's kind of open for the medical director's determination of when it can be used. So are the drug profiles that's put out by the state in this committee, are those considered guidance documents or just resources, educational resources? How are those viewed?
Really both. I mean, just like we have our treatment guidelines or guidelines that any medical director can adjust for their own entity, these are similar. This was an ask from the training centers. Most of the paramedic programs utilize the state drug profiles for their paramedics. And so when we're transitioning from the old format to this, there was a request to make sure that we please did include drug profiles for that purpose. So this is really a kind of more of a reference, but it is guidance, as mentioned previously. Once it's on table 1, it's really up to that agency's medical directors to make determination on how to use it.
Got it. Just wanted to clarify because some of the language that it sounds like is restrictive in the language, but I didn't know how far that carried. I'm all done. Thank you.
And I think we have done that before. Historically, we have this committee and MDC has approved certain medications with a limited scope. And individual medical directors have used it for other indications. So that is within the purview of the committee and really up to the jurisdiction of PMD and MDC ultimately for final decision. But that has definitely occurred in the past where MDC approved a medication for a specific indication, but individual medical directors used it for other indications.
Any further discussion?
Just, this is Noreen. Just on the regulatory side of it, I believe the department is obligated to provide these, but there's no obligation or no regulatory reference that requires the medical directors to use them.
Thank you, Noreen.
And just for just to make sure everyone understands the process, once the drug tables are approved at this committee, it goes to MDC, and then if MDC approves it, any changes ultimately go to the director, which is Dr. Christ, for final approval before publishing. So just from a housekeeping perspective.
This is Dave. Also, the Bureau's website under guidance documents, drug profiles is not listed anywhere in the document as a category, so something to consider as well.
David, can you repeat your point, please?
Sure. And the Bureau's website under our regulatory documents, under guidance documents, drug profiles does not appear anywhere as a category within that section.
Thank you. Is your point being that it ought to be as part of the offered services?
Well, I don't know. If you read what constitutes a guidance document, it states a guidance document means a record of general applicability developed by an agency which lacks the force of law, but states the agency's current approach to or interpretation of law or describes how and when the agency will exercise discretionary function. So that's kind of a wobble. It's a gray area. Maybe it's something to think about as we'll not include it down the road sometime.
So,
all right, thank you.
Yes, just thank you for that clarification, David. These are not technically a guidance document because that is something that goes through Office of Administrative Counsel. So this is similar to a guideline. These are an appendage or addendum to our triage, treatment, and transport guidelines, so the TCTGs, which are purely optional and just as a resource.
Okay, so basically added as a reference resource for somebody to review. Any further discussion points before we move, call for a motion? Or, so can I go?
Franco, my only ask is with the final motion, if we can just run through the exact verbiage just to make sure we capture all of that for Shelley.
Yeah, if I could get an assist with that, because I don't have anything visual in front of me other than the original version, but I'll try my best here. So we have the pharmacology and actions bullet list that I did not hear any amendments or changes. On indications, did we soften up the word must administer within 3 hours then? Or remove that altogether?
I think we were removing that from the indications, and it would be
under precautions.
Yeah.
And then we're still keeping heart rate and blood pressure as separate components instead of combining. And then on absolute contraindications, we also added on indications that we're going to open up to significant hemorrhage, whether they are traumatic in origin or not. We are removing the recommendation to use in patients only over 16 years of age. We are removing the greater than 3 hours from time of injury and adding that to precautions and side effects. And I believe that's all I had.
This is Erin. I would just add that I thought the literature, there was one of the studies that if you gave it at greater than 3 hours, there was actually increased mortality. And the reason that we're justifying using this in the pre-hospital setting is because of, a prolonged transport. So I don't understand why we would want to remove that 3 hour limitation from this guidance, or make it only a precaution and not a contraindication.
Yeah, that was my recollection as well. I thought the crash trials had mentioned something about increased mortality beyond with administration beyond 3 hours.
To echo the similar thing, that most of the data these days showing benefit and no harm, again, is for the under 3 hours. So I can see where we're coming from there. Yeah, I would defer to the group to see if they think to keep it in there as greater than 3 hours as an absolute contraindication.
Yeah, so any other comments on the 3 hours? So it sounds like I also would support leaving the 3 hour limit in place under precautions. Is there anyone specifically opposed to that?
That sounds good to me, Franco. This Garth.
Thank you, Garth. Were there any other edits that I missed? If anybody else is keeping close notes? All right. Then can we get a motion to approve the drug profile for tranexamic acid with the edits as listed?
Motion to approve. This is Garth Gamer.
Can I get a second?
Ryan, second.
All right, call for a vote. All those in favor say aye.
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 Aye. Any opposed? Anyone abstaining? All right, and the motion carries. Thank you very much for the discussion on that and for our presenters on the topic. Next item is to discuss the NASEMSO model, EMS clinical guideline updates and a timeline for updating the Arizona T3Gs.
Yes, thank you. I just wanted to keep this committee just reminding as those are getting closer to their kind of point that they'll go to public comment at the national level. Once those complete their comment period at the national level, they will get published. The goal for publication is beginning of 2022. And then as soon as those are published, we will really want to start looking at our process for updating the TTTGs. I think it was a huge project when we did this the last time around. I see Shelley's got some PTSD next to me from that still. But we've, I think, definitely learned some best practices. And the one thing COVID has taught us all is to how to do things electronically and simultaneously. So I think moving forward, it hopefully will be a smooth process. But I just wanted to keep that on everyone's horizon. The plan will be as soon as those are published or getting close to publication at the national level, we will start getting a sort of projected process on how to do that through this committee. So PMD was the group that really took the charge and did all the work for that publication last time around.
Thank you very much. Looking forward to that. Next item, discuss, amend, and approve amending Table 1 to allow for a more limited drug box to be used in special deployments such as wildland, TEMS, and cruise that cover special events that are not attached to an ambulance, such as bicycle teams, UTV teams, etc. Any discussion there?
Hi, this is Brian.
Go ahead, Brian.
I'm a little bit confused by this statement. Is this going to relate then down below to certain drugs that would be going in there, or should it perhaps say a limited drug box may be used in special EMS circumstances with an approval of the administrative medical director? Or is that going to get tied to certain drugs down below?
That's a great point. My question also has to do with whether or not DHS has any regulatory oversight on that requires this discussion as it relates to paramedic crews operating detached from an ambulance. Am I wrong to say that my understanding historically was that we have regulatory oversight over ambulance equipment, but there's not. I'm not aware of any regulatory oversight over mobile or individual ALS drug equipment beyond table 1.
It's in the administrative medical director rule, and 201 basically says that the agency, and then for those who would be associated with a base hospital, have to have a policy that says the minimum quantity of agents will be available to the provider based upon their level of certification.
And so to me that sort of allows the scalability for these kind of deployments as basically up to the base hospital and or administrative medical director. Is that a fair statement?
Well, you still have to meet all the quantities that aren't listed as optional. So you can get away with.
I think just for clarification, if I can quickly speak up here. So if anyone is looking at the online document with the proposed wording, and I do like your addition of the word may, Brian, in the second paragraph, the last 2 lines specifically state the administrative medical directors must, in all caps, ensure that every EMCT operating under their delegated medical authority has access to the minimum supply of agents required in the table below, consistent with the EMCT certification level. So I think that's pretty clear in terms of that. What's come up as a question is in regards to settings where it may not be possible or ideal to have the full normal minimum drug box. And so that was the thought behind potentially adding this language. So the potential language would be, per Brian's suggestion, a limited drug box may be used in special EMS circumstances with approval by an agency's administrative medical director, and then kind of listing out specific scenarios. So that is the proposed change, but just for clarification, there's no mention of just ambulances. This is specific that any EMCT would have access to the minimum drug box.
Well, then the other question is what defines access, right? Because a lot of these deployment examples, the drug box is there, the complete drug box is there. It's just a matter of distance, right? I mean, there's always some sort of base out of which even these smaller, more agile teams operate. whether it be wildland, Thames, or otherwise. These are usually deployments that are occurring with an ambulance that's staged within some unspecified and unregulated distance, physical distance. And so again, I ask, is there really a loophole here that needs closing? I guess is what I'm asking.
I don't know that you can always count on that, though. But in a wildland situation, you could be very, very remote from where an ambulance might be at the EMS unit. And I think that's true. Most UTV should be able to carry a regular sized drug box. But on some of these others, you could be very remote and not have a number of things limiting by the number of people, crowds, and things like that, where you would want something to be carried with you.
And I think the reason the UTV was put on there specifically, Brian, was some wildland deployment crews have stated that based on the fact that they often have to leave the vehicle to then walk a separate distance, they didn't necessarily want to have controlled substances, which with the current version they would. So I think that was why that was a request to include that. So even though they could potentially have, from a size perspective, a full drug box, based on the environment they're working, there was a request to not necessarily have a full drug box.
This is Sandy. I think not only with your wildland, but you have to think about your search and rescue teams too, because they are very limited in what they can carry, and they are very remote a lot of times.
Yeah, but I guess my pushback with all of that, I mean, I fully understand how these teams work in terms of having to be away from in very austere conditions and are very concerned with how much weight they have to carry to get to a patient, et cetera. But the language just says medical director must assure availability to. And so I don't see how deploying a search and rescue team within a smaller pack, but yet, packing out of or basically based out of some central location. I mean, they have to be deployed from somewhere. And so, oftentimes with search and rescue, whether it's wilderness or urban, you have a base of operations staged somewhere. Otherwise, those people are not deployed properly. So technically, the medical director has made available the entire drug box, even if two paramedics walk away from said drug box with a smaller cache of materials that they feel are necessary. It's just a matter of distance, which is not specified.
I think we also have to think too that some of these search and rescue teams are not your typical EMS personnel. They are law enforcement.
This is Noreen again. This has come up many times, especially with tactical, with police officers that have paramedics. And historically, what the department has done is not put language in like this because it's a potential rule conflict, and just leave it to the medical director to define, since we don't define what has access to means. We leave that up to the medical director.
Thanks, Noreen. And that's the point that I'm trying to make is, if you use, so with urban search and rescue, we carry the entire drug cache, but we send out foot teams with much smaller, as needed equipment all the time. And we're always massaging our drug caches to the appropriate mission for that day or that afternoon. And it may just be take with you what you can fit in your cargo pants, and that's it. But the main drug cache is still available either at a base of operations or even at the outskirts of the hot zone. And so, I know that wildland works on a much larger scale, but so do hurricane deployments at times. And I don't see the difference. The medical director has the things available that are necessary. It's just a matter of they may not be available on your person. And the way that the statutory language reads to me is that I'm still able to be agile with those deployments and not be in conflict with current statutory language.
This is Garth Gamer. I think everybody wants to get to yes on this topic, and And I think with Brian's suggestion about putting the word may in instead of the word to, along with the wording that follows, I think it allows us to do this because a limited drug box may be used in special EMS circumstances whereas the previous paragraphs probably refer to more standard 911 practices. And so I think the combination of all the wording allows what we want to do with this. You know, I'm not an AG's rep, but I think we're probably on pretty solid ground. The only other thing I was going to bring up is, do we open end this to? And I can't think of other instances, but just the 5 examples listed, does that limit us in some way? Like, I don't see stadium walking teams there, for instance.
But see, that's the problem, is that, you know, what's being suggested that we do here with this language paints us into a corner where we have to what if all these scenarios. But yet, as Noreen pointed out, in its current language, I don't see any of these deployments in violation of any of that. And it seems like the vagueness of the current wording is either as good or better than the vagueness of the wording that's being suggested, because then you could get into semantics of, well, what do you mean special? What defines a special deployment from a non-special deployment? You know, the condo collapse in Miami is a special deployment, but it starts as a 911 call. So my point is that we either have a version of vague language that we have now, which at least I'm not an attorney, but you know, we've been operating these austere teams for years, and it's never seemed to be a problem. You know, why is it a problem now? And we're just substituting one vague set of vague terms for another set of vague terms that then require further refinement and definement. That seems to be an endless pursuit.
Question: how, as far as the special deployment or wilderness environment securing the drug box, I know R925-206 talks about the pharmacists at the base also have to be responsible to ensure the access is controlled by the EMC team. We've had lots of situations where agencies get in a lot of legal jeopardy because the drug box gets access unauthorized. So how are we going to secure that and make sure we don't get out of compliance with 206 of our regulations?
Well, a lot of drug box requirements in terms of securing and locking and clean the boxes and, you know, secured to vehicle and all that sort of thing. A lot of those are spelled out in guidance language from Arizona, from the state, that has been put out. That was created, if my recollection is correct, on DOJ. Office of Diversion language and suggestions, but again, a lot of that is sort of put into the medical director's lap at an operations level.
Or I'm going to smack you. Do not tell me no. Do you hear me? Do you hear me?
If you're not speaking, can you keep
Try
your phone on
again.
mute?
Open your mouth bigger. Change your attitude. Go brush your teeth. Go.
Hi, it's Brian. So the issue of diversion is, I think, clearly defined and really doesn't. It's only over controlled substance. It's not over every drug in the drug box. And if you go look at that section under the administrative medical director, where it talks about the policies and procedures on that, I think it's well covered to allow, if you've got controlled substances, you have to meet one of those. I think there's 3 different criteria that it can fall under, and one of those is having it on your person. So I don't think that's the issue of diversion. I don't think is an issue here, as long as you're meeting what the rule says it is right now.
Thank you, Brian.
And I think this is a pretty simple fix. I like Brian's suggestion and would support the addition to the statement: a limited drug box may be used. Blah 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 blah.
I think for cleanliness, I don't think we ever actually got a motion to discuss, amend, and approve. So if we can get a motion, an official motion, and a second for that, please.
So moved.
This is Amber. I'll make a motion.
Second.
Thank you, Dr. Bradley, for that. I apologize for missing that. To Dr. Gaither's point, that's fair enough. My only counter is that the even easier solution is basically to sort of agree as a body that the current language already allows for the breadth and depth of all these special deployments in its current form, and actually not requiring any additional edits.
This is Amber. I think where this does have somewhat of a benefit is I think that it specifically outlines that any limited drug box that would be used has to be done so with the approval of the agency's administrative medical director. I think that there have been instances where agencies have interpreted that the current statute much more loosely, and have had providers that have taken drugs from drug boxes and carried them for other reasons, which you could definitely call a sort of limited or special circumstance, and not necessarily with the approval of the administrative medical director as to what specifically you'd be taking. So I do think that this language, although in some ways it doesn't conflict with the current rule, but I think that it strengthens the administrative medical director's role in the limitation of what can be put in a drug box for a special deployment, and not leaving it up to individual providers to take what they feel like they want to take on any given circumstance.
Just a time check. I think there's a motion and a second on the floor.
To approve, what was the motion? To approve?
I think you made a motion to approve.
I did make a motion to approve. Or discuss.
I understood it as a motion to discuss. Is that right?
Yeah, I will move to make another motion to, as amended, approve the addition to the EMCP drug box table 1.
Second.
Brian, can you give us or can I get a second, please, to approve? And Brian, could you give us a summary of what the amended language will read?
It would say a limited drug box may be used rather than to be used. A limited drug box may be used.
And then the second part about special circumstances, is that right?
Yeah, all the rest of it is the same. It's just really changing the to may after a limited drug box.
Okay. Can I get a vote? All those in favor of the change as summarized, as amended?
Aye.
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 Any opposed? Any abstentions? All right, and the motion passes. Thank you. Agenda items to be considered for the next meeting. Any call to the public? Upcoming events, there's going to be a free 4-hour virtual traffic incident management training course with CEs awarded. The dates with registration links are posted on the agenda, August 12th and November 9th. July 14th through 16th, the Western Paramedic Trauma Conference will be held in Huntington Beach, California. That's actually happening currently, it looks like. And October 7th and 8th, the Southwest Trauma and Acute Care Symposium will be happening on a virtual platform. Please visit the Bureau's news and conference page online for any additional upcoming events, as well as upcoming CE opportunities. The next meeting is scheduled for November 18th, 2021 at 1200 hours with location to be determined and electronically. Any other comments before we adjourn? Thank you. We'll go ahead and adjourn at 13:28. Thank you, Shelley. Thank you, Dr. Bradley.
Thank you.